Welcome back to the Journal Club of Justice, an online journal club made up of a small group of friends who meet once a month to praise, scrutinize, and discuss research of the physical therapy nature, one article at a time. Could be new, could be old, but we feel it will create a good discussion that will influence our practice. We hope that you will get as much out of this as we do. We do ask you keep in mind new research is always coming out and progressing, so do not take any of what we say as medical advice, facts, or clinical suggestion. Journal Club of Justice here. We're at CSM 2018 down in New Orleans. Great time, a lot of learning. We got Dylan Collier here of the New Medical Notes podcast, who has enlightened me to that this weekend is not all about learning. So I want him to kind of expand on what he's been doing instead of learning.
So I got to bounce here, guys, here pretty fast, but a couple minutes. I use conferences as a networking opportunity in order to match with people that I've met with online, and also to talk with other people that I'm passionate about, or that are passionate about the same thing. So being a traveling physical therapist, there's a lot of students out there, there's a lot of new grads out there that are really excited and want to talk about it, want to learn more things about traveling physical therapy. And so if somebody wants to talk and it happens to go into a lecture, I don't worry about it. And so instead of going to lectures, I actually go here to learn from the other people, talk to them, teach them what I know, and then also check out the exhibit hall, get to meet other companies, see what they think, network a little bit that way, maybe work out some other opportunities that we've been working on kind of separately. But yeah, so conferences, worth it for lectures, but not only that, also worth the connections that you make in the real life interactions that you have that will carry you further down your career. But that's all I got. I'm gonna get out of here.
All right, thanks,
Bye. Have fun doing traveler things. Sorry.
All right, so like we mentioned, multiple things that you can come here for, get a lot of good out of. Numerous awesome people come down to speak and, educate the, 17,000 therapists down here? Over 17,000, okay. So we just wanted to kind of highlight, instead of, reading an article, kind of discussing it, we just kind of wanted to highlight some of the things that we learned over the past week and let that kind of discussion kind of go where it goes. So you guys want to start with your...
Sure. So I am April Ritz. I am an outpatient orthopedic and women's health clinician. So I went to a lot of them regarding outpatient ortho and women's health. So some of the ones that I really took away from would be, one of them was called Advanced Cervicothoracic and Shoulder Interventions for Upper Limb Syndromes. That session actually was completely booked, and even the overflowed. But it was just talking about with lateral epicondylalgia, how you need to be looking at just more than the elbow, looking at the shoulder, looking at the neck. They found a lot of research they presented on was that cervical moves and manipulations can help lateral epi, as well as just doing deep breathing, nerve glides, and just general pain education. So it was kind of refreshing what we already knew, but it was good to see the research behind it and just to help us remember, don't focus, if their pain is only here in the elbow, don't focus just on the elbow. Look at above and below, like we're taught, in PT school. Do you guys want to talk about any of yours, or I can go to the next one? Okay. Go ahead.
Yeah, we can do it in the format. Yeah, right here.
Okay.
You just kind of run through your list of your big takeaways.
So the last class I just took was great. It was with Chris Powers and Dr. Weber and then Jenny, and they talked about FAI, or femoral acetabular impingement. So I currently have a patient with that, and sometimes it can be hard to figure out what's the best treatment for them and what rehab strategy you should take. So they talked about a new idea that I had never heard about, but it's doing static holds to help with glute amnesia. So instead of doing just fire hydrant exercises and just doing reps of those, they are encouraging you to do static holds. So holding your leg out in hip abduction and extension with the TheraBand around the legs, and holding that for a full minute for endurance, and doing that 2 to 3 times a day. Yeah, and just holding it up there.
So I mean that ties into some of the stuff with like tendinopathy research, which we'll touch on it a little bit here. So we'll leave it till later, but made me think of that.
Yeah, so they had done research for on this with glute medium amnesia, and they found that by doing these static holds, within 1 to 2 weeks, the primary motor cortex had increased activation, like a wider surface area of the brain was activated by doing these static holds and helping the brain make those connections with the glute. So the patients who haven't been firing their glute for a while know they're starting to realize, oh, I can pick up on this muscle, I can make it work. So I thought that was really cool. And they also do it not just with fire hydrant, but they were doing the static holds, isometrics for a minute with clamshell, sideline hip abduction, pretty much any exercise that you can do for the glutes.
Any exercise, any position. I mean, especially with maybe like a overhead throwing athlete comes to mind, where they need to be strong with their external rotators, and all the way back here to all the way through the follow through, doing those holds, in different positions, until they can tolerate going through the full range of motion.
So some of the other classes I took, the very first one I took yesterday morning was on golf and total joints. And so I like to play golf, but I'm not a golfer, and my swing is awful. So it's good just to hear from the experts and the professionals on the proper golf swing and how we as physical therapists can be treating our patients. Because majority of our patients are older patients. I know in my clinic at least, I get a lot of them that are golfers, and after their total hip or total knees, they're like, when can I get back to the golf course? And I never really knew how to make sure I was progressing them correctly to get them back to the golf course safely, so they're not affecting another joint in the body. For say example, they had a total hip, that they're not using all like lumbar and trunk rotation and causing back pain with that. So just knowing how to treat that and look at the golf swing was good. Some of the other ones, like I said, I took 3 pelvic classes. So one was male pelvic pain. I don't treat males currently, but it was just I wanted to take this class to see if how I felt about it, and if I was ready to get into that area. And I learned a lot about some of the other male issues that women don't have, such as with prostate issues. Another class that Emily and I both took was management of the pelvic floor dysfunctions with female runners, and that would just kind of reiterated, making sure the pelvic floor is strong. If they're leaking at a certain mileage and having incontinence, say at like mile 5 in their run, making sure you're checking for prolapse, maybe recommending them to go back to the doctor for a pessary. So just kind of reiterating what I'd learned in the past. And then the class that really stuck out to me, and we both took this one as well, it's not about just sticking it in regarding vaginal dilators, or the term that they use was vaginal trainers, more patient friendly. Sometimes patients, when they hear vaginal dilators, it kind of scares them. So that was a great class, and I have been doing pelvic therapy now for about a year in practice since I graduated about a year ago. And I really I knew the basics. So I knew you could insert it to help with stretching, and you could do some static stretching with it. But I never thought about doing contract relax work. So I'm going to start implementing that with my patients this upcoming week when I see some of them in the clinic. So those were my main takeaways, as well as the blood flow restriction training we went to outside of CSM last night.
Yeah, that was awesome. Do you need to get out of here?
I'm good. Yeah.
Okay.
Yeah.
Okay, go for it.
So, I'm still a student, currently in my final year at Maryville University. Like April, I also have an interest in outpatient orthopedics and women's health, so you're getting a little biased course selection here. But something I went to yesterday morning that I found super intriguing and super interesting was an update on the evidence of urinary incontinence. The speaker, Carrie Bow, she was amazing. She's Norwegian, and she's done a lot of research. If you know anything about pelvic health, you've probably seen her name out there. And she mainly focused on stress urinary incontinence and diastasis rectus abdominis. And my biggest takeaways from that is that she said people really need to be properly strength training the pelvic floor musculature. And when she means that, she means you train it just like you train any other type of muscle. So a lot of times she's talking about women are just like, hey, we're gonna work on your pelvic floor now, so I want you to relax, and then we're gonna contract and breathe, and so much more of it is like when you're out, working out your biceps, you're not like calmly speaking to your biceps. Most of the time you've got like upbeat music going, and it needs to be like a good maximal contraction. And then on the diastasis rectus side, she said, honestly, there's, not really any good evidence out there at all about it. And some of what we think, we've been doing right for so long is not. And one of the things that she mentioned is that the typical like drawing in technique of being quadruped and kind of bracing and using your transverse abdominis actually has been shown to create more opening of the diastasis rather than closing it. And also doing pelvic floor muscle contractions has also been shown to open the diastasis and then close it. So she said, more research needs to be done about what we can actually do to treat this condition. And she also brought up the point of whether it needs to be treated. Obviously, it's a cosmetic problem, but what other type of problems it actually causing with our patients. So, kind of looking into that. And then she said, right now the thing that has been shown to at least not open the diastasis more and semi-close it is going back to kind of the noble techniques. So April's got a little gift.
Oh yeah, so talking about pelvic floor strengthening. So with the exhibit hall that Dylan and Adam were talking about earlier, you can get a lot of free good stuff. So I got a little Kegel strengthener. So this weighs, it's one of the heaviest weights, but it was one of the ones they had there. So this is from Intimate Rose. It was a company that was here, and they have a whole system of vaginal weights. So typically in the clinic, I do not use vaginal weights with patients. They are an option. So when I discharge patients and they're doing a lot better, I can recommend these to them if they want to go home and start using vaginal weights. But I just wanted to show an example of something that's kind of fun that you can get in the exhibit hall for free.
Is that like a stress ball? But
No,
it's a vaginal thing.
It goes into your,
oh, that's hard.
yeah.
Yeah, it's a weight.
Okay.
So it's an actual weight.
It's
You
not
put
like
it,
a
real
1 or
weight.
2 pound
Okay,
weight,
gotcha.
but it's
yeah.
a weight for your vagina.
They weigh them in ounces.
And vagina is not a dirty word.
Yeah.
We need to be saying it more.
I
Sorry,
don't think so.
Sorry, kids.
We're getting a lot of women's health out here right now. So then we also, Adam and I went to a tendinopathy and dry needling course, and I'll let him speak about that a little bit more, but it was really interesting. And then I went to the dilator vaginal trainer course with April, like April just discussed, which was super eye-opening. It's not something you really learn a lot about in PT school. It's kind of something you have to go find on your own. So I walked in not knowing a whole lot and walked out like mind blown and like, this is really cool. So this morning, April and I went to the running and female athlete runners and pelvic floor incontinence, and kind of the same thing. It was more of your basic, just like, here's what your pelvic floor does. And they talked a lot about using like the Perfect to do your training and like your dosages and your assessments. And then afterwards, making sure with return to running that they are good in all aspects, pelvic floor and just like general injury prevention before you just kind of, okay, look, you're allowed to run again. And something interesting was they are developing a test at VCU. It's like a return to running type protocol, like a five task test to kind of allow, instead of your athletes, them asking you, hey, when can I start running? You just saying, well, I don't know, saying, or not yet, because nobody likes to hear that, or it depends. Nobody likes to hear that. Giving them an objective measure of when you can complete this, that's when you can start running again, which, I mean, as a runner myself, we tend to be a stubborn-headed group of like, I need to run and I need to go run now. And so that was, something that I think is definitely beneficial for this population.
And I wrote down the 5 steps to the test.
Yeah.
I think they were each in for a minute, and one of them was just hopping. One of them, what was the other one?
It was the wall sits, single leg squats, a plank,
and step ups.
And just making sure they have good form. And if they fail one, they fail it all. So they can't run until they pass all. But they said that's getting published within the next few months, next year. So that should be made available soon. And
That's
then
all a minute.
A minute each.
yeah.
Yep.
I think one of them was, I think the single leg squat
Was 30 seconds one leg, 30
one-
seconds
yeah,
the other leg.
but adding up to like that. And then I went to optimizing bone health in our athletes, and they tended to focus a bit more on the female aspect, and it was through the continuum of the lifespan. To me, it was kind of a refresher of things that I've already learned in school or been exposed to, but the biggest takeaway was, you need to be, heavy loading, heavy, like multi-directional. So, a lot of people used to think like, oh, running builds your bone health, which it does, but maybe not as well as like soccer or basketball or some type of sport, some type of activity where you're getting that multi-direction challenge and you've gotten like a little bit more of a high impact where you're jumping and landing. And so definitely like high intensity resistance training, heavy resistance training is also really beneficial, and it's beneficial.
That hard muscle pull on the bone.
Yeah.
Essentially.
Yeah, and it's and then the importance of female athlete triad and screening that in your patients, and going to a course on that tomorrow morning. So maybe catch up with that later more. But this was just more of like an overview of female athlete triad.
I think the most important thing, because we all see athletes, we all do at least, and just asking them, I mean, when they come in with whatever condition it is, always asking them to, especially if it's with lower extremity, if they're having any pelvic pain, if they, I mean, even if you're a male, we need to be asking this, if they're having any incontinence with any of their sporting activities, and then just doing a basic screen for female athlete triad, because if they're not getting the correct nutrition, we already talked about female athlete triad, so I don't want to go into that again, but just those three
You can
things.
refer to episode 4, 5, whatever. There's one or two episodes ago.
Yeah.
We don't have that many out yet, so you should be able to find it.
And then really quickly, I just went to a panel about, women's health residencies. So if you are interested in any type of residency and there is a panel about it, I would suggest going. You get a lot of information. You get to network with people, important people. So it's a really good opportunity, and you should take advantage of it if it's offered.
Yeah. Nice. A lot of information there. Let's keep it rolling. All right, so I started the week off with an awesome debate of form versus footwear. A little debate between Blaise Dubois and Rich Riley. If you're not familiar with either of them and you're into running or the endurance world at all, I'd highly encourage you to seek out some of their research. A lot of great work there. So Blaise is from the running clinic. They do a lot of work with footwear, and kind of they created the minimalist index, which is just a measure of how close a shoe is or how far away it is from being barefoot. He's a big proponent of being more towards that minimal line or more barefoot, and letting that kind of alter the way the foot is floating on the ground and how that kind of interacts with the kinetic chain in order to create changes in gait, changes in function and pain and everything. And then Rich Riley was talking more about changes in your step rate, changes in using mirror training to kind of look at step width and different various modalities of that to kind of change gait and how the body's being loaded, so that can kind of alter the pain that you're having with running. I thought a big takeaway that he mentioned twice, so his PhD dissertation was in regards to, that led him to this bias of the changes that we make in the clinic need to last forever. So he was really bought into this idea that people need to come in for tune-ups and make sure they're still running the same. But what he came to find out was that people's pain was still better sometime down the line, even though they reverted back to their old habits. So it's interesting, really. What we just need to do is modify things for a little bit, play with the load management, which also ties into tendinopathy and really a lot of our running related injuries. 60 to 70% of our running related injuries are just training load errors. So if we can just modulate that training load for a bit and let the system kind of calm down, and then we slowly build it back up, you're good to go. And then kind of hit it now. Before we go into tendinopathy. Oh, no, we did. Yeah, so tendinopathy. They kind of, the first half of it was really a lot of, starting out with Jill Cook's work on the kind of the continuum of tendinopathy, how you do have degenerative changes, and kind of we need to think about the tendon as being more of a donut. And so the outer portion of the donut you would eat is kind of that good, healthy tissue. The inner portion is that degenerated tissue that we probably can't have much of an effect on. So you can scrape, you can stretch, you can tape, do this, that, and everything. But we're not really having much effect on that center portion of the tendon where the cells are not really that active. So what we need to be doing is loading that tendon first through isometrics to help with kind of that pain, so we can kind of get back to function, moving, tolerate the isotonics, and then we just need to very slowly and progressively load that tendon, build up that healthy tissue around it, whether that be heavy slow resistance, eccentrics, just some way to overload that training. And then
head out for my next thing.
Okay.
yeah,
All right,
April.
bye,
See you
guys.
later. And then it's interesting that it doesn't seem that the cortisone injections, the PRP, the prolotherapy, etc., all of those type of needle treatments towards a tendon don't seem to be too effective. That, or the research that we do have on it is just not really that great yet. And there wasn't much on the direct benefits of dry needling with tendinopathy. I mean, all of it right now is kind of more theoretical, but the idea is that they kind of perforate the tendon a little bit, creating some inflammation, kind of re-stimulating that healing response a little bit, kind of going back to an older thinking of like the cross-friction massage type of thing, where you're trying to restart a stalled healing process. We'll see what happens with that, if there's anything good that comes out of that. But right now, kind of our best thing is to just load it and slowly, progressively kind of build up that activity tolerance.
Heavy, slow resistance.
Yeah. All right, so then the last thing I want to talk about is the emerging technology in running analysis. So we know that you go into a lab and you do the 3D analysis, you get the motion sensors on you. That's kind of our gold standard, but it's not clinically relevant because not everybody can do that, not everybody can afford it. And it's also usually a 2 to 3 hour process. So they went into a lot of the kind of using your watches, using kind of some foot pods, some other sensor technology that is actually showing a lot of promise and is going to give us a lot of really good data here in the coming years. That should give us a lot of information on, how do we return these athletes in a safer manner? How do we prevent them from getting injured in the first place? And a lot of them look to be, pretty reliable. We still have, there are still a few data points that are still just not quite, sensitive enough to register. Their ceiling for their ability to measure is just not as good as what it would be on like a force plate. So, it's up and coming, and it's very exciting to see kind of where we're going to go with this and what we're going to learn. And especially important to know when you have, someone who's kind of like a data geek a little bit, and they come in with all their data from their Garmin device showing their heart rate, their cadence, their vertical oscillations, their impact force, just so many data points. How do you kind of make sense of that? Because they want you to make sense of that so they can understand it better and not just kind of disregard it. So it's a way to almost kind of create some therapeutic alliance with that patient that's very kind of hard-nosed on the data and want to know how they can utilize it better.
Okay, so we're a couple days past CSM now, and just wanted to highlight a few things that I was thinking about and that Em and I talked about on the way home, as well as I realized I forgot that I didn't talk about blood flow restriction training at all, which is really cool and upcoming, so I want to spend a minute talking about that. And blood flow restriction training, or BFR, is an awesome kind of workaround for those who you are unable, or they are just unable to tolerate heavy loads or higher intensity interval stuff. Basically, what you do is you occlude some of the blood flow, specifically the venous return, and only, I think what I've heard is just about 80% of the arterial flow. And what that does is create an environment that kind of simulates a high stress, high load environment where metabolically you just can't get rid of those metabolites, and which helps signal a lot of the hormonal responses to what heavy loading usually does. That helps to stimulate hypertrophy, muscle growth. So it's, if you haven't heard about it, definitely look into it. It'd definitely be worth your time. Sounds really promising, a lot of up and coming research. I'm sure you'll be hearing about it shortly in some time or another. Another thing I want to talk about was April mentioned a lecture she went to with Chris Powers. I just want to highlight that if you need to check out Chris Powers' work for a lot of the hip and the knee. He does a lot of phenomenal research out of USC. And then wanted to touch base on one other aspect. I was thinking a little bit more in regards to the tendinopathy and why the lectures and some other people may find dry needling to be really successful in those patients that aren't responding to load, which was one of the parameters they were outlining to before you maybe go this route, or maybe before they go this route with their patients. They want them going through a loading program at least 6 months. So that's pretty intensive. I mean, you're giving it time, and if that patient's still hanging around with you, by all means, you need to be trying some other things. So with dry needling, one thing to consider with that is that it is more invasive. There's more to it. Which creates a lot like surgery, just this massive expectation to get better, whether it works or not. So just something to consider when you're thinking about it, if you do it, if you don't do it, if you're thinking about taking a course on it, etc. And then the last thing I want to hit on was the last course I went to Saturday morning after our recording. I was on motivational interviewing, and this is a huge piece. Nothing really new, but stuff to highlight. And it's not necessarily a technique that I practice motivational interviewing with my patients. It's something it's more on more on not necessarily what you're saying, but how you're saying it, kind of framing things in a positive light, not being blameful or judgmental, which sometimes we can be, and it's easy to do with patients, like, oh, you're not doing your exercises, that's why you're not getting better. So framing things as into kind of digging deeper, like, why aren't you doing your exercises? What's getting in your way? What is this even a good time for therapy? It's a way to kind of start to dive deeper, and get to some of those components where you might be able to identify if someone is even right for therapy, or maybe they need to be referred on to a different healthcare practitioner that can maybe deal with some of the issues that they have going on in their life, or issues that they have going on with themselves. So anyway, just wanted to highlight a couple other things and in regards to some of the thoughts I was having on the way home, thoughts I've had since, and then hit on the blood flow restriction training, which was an awesome opportunity. I really want to thank the human performance mechanic and then for getting that set up down there, because I was outside of the CSM conference itself, which is something you need to be looking out for if you're going, but any other time in the coming years. There's a lot going on. You're going to be busy. It's going to be exhausting, but you're going to get a lot out of it, and it's totally worth it.
So that's kind of just a quick rundown of everything kind of we've been through. Highly encourage you guys to get out to CSM if you ever get a chance. Awesome opportunity. A lot of networking that can happen, a lot of learning that can happen, great speakers to touch base with. A lot going on in the exhibit halls where you can kind of learn, get involved with different companies, get involved with different products. Just so many opportunities here. You got to make it out if you get the chance at some point in time. So until next month, this is Journal Club of Justice signing out. Hope you guys enjoyed it. If you have any questions, comments, concerns, suggestions, shoot us an email, follow us on Instagram, Facebook, kind of all over the place now. We'll see you next time.